Good. Okay. So thank you very much for inviting me today. As this workshop series has so ably established, the categories that we use in epidemiological data are cultural artifacts linked to the politics of inequality. And I'm interested in this because the historical decision-making processes that mark out particular categories as being either linked to the environment or to the individual's constitution or lifestyle were a crucial part of the process of determining an individual's health status as either normal or pathological. And so as a disability historian, it's this particular use of categories to establish disability as either genetic or environmental that I'm especially interested in. And in fact, as Freya said, I've got this new 5-year project starting this year that will be investigating categories used to establish and moderate disability in 20th century Britain. And I hope that I can align this work with the Hidden Epidemics Research Network over the years ahead. And my main thesis is that the data points that were used to establish normal health were validated in early 20th century Britain in two main ways. First, through classical genetic statistical calculations used in the eugenics laboratory to establish inherited disability. And secondly, through the moderation of compensation systems for acquired disablement. And both of these systems separately organize data to differentiate biological from cultural predictors of health. But what I want to do in this talk is look at a specific example of how work coming out of the eugenics laboratory can be viewed through a disability history lens by focusing on one particular project, the Treasury of Human Inheritance. The Treasury of Human Inheritance project was an extensive compilation of genetic disorders published between 1909 and 1958. And although it's really important not to simply equate disease and disability, and it hasn't been done much in the historiography, it's also true that as people like Linker and Abel have recently pointed out, the two have had an intimate relationship for centuries. So accordingly, this talk explores the complexities of this relationship, highlighting instances of torque and tension between the categorization of disease and individual experience of disability, as well as the disabling impacts of inherited disease on family members who might not have felt its effects directly. So the Treasury of Human Inheritance, it included published and unpublished family pedigrees. And doctors like Julia Bell worked closely with families to validate these pedigrees, to make sure that they were actually real, as often as she could. And the aim of the Treasury was to provide material that would illustrate human inheritance for students of heredity. And it formed part of a much broader connected body of research into inheritance in the first half of the 20th century, which was administered by multiple institutions, including the Galton Laboratory, the National Hospital, and the Medical Research Council. And a major part of Bell's work involved actually going to visit these families, and obviously not the kind of really old or overseas ones, but certainly the more recent ones. She would try and actually go to people's houses and work quite closely with the people there. So this was something that required a sensitivity to the domestic that I think was probably something that women were seen to be more suitable at doing. And this is something that Margaret Rossiter talks about in her work on territorial discrimination. She described how jobs, especially those related to women or children, could be a way for women to work their way into science through kind of backdoor pathways, as it were. So for example, she worked with mothers in particular a good deal she relied on them to provide the family histories, not just of their own immediate families, but of their cousins and second cousins and really the whole extended families and relatives. And obviously the kinds of things that Belle's talking about it required a great deal of sensitivity, and it was a difficult subject to broach with mothers who were particularly worried about the onset of disease progression in their children. So for instance, she visited a family in 1943 and was trying to work out with them the average age of onset of symptoms linked to pseudohypertrophic and allied types of progressive muscular dystrophy. And she recorded that a mother told me how she anxiously watched her children daily to see how they picked up a cup, having noticed some little trick in the use of their arms as the first sign of disease in members of her family. And mothers, they often confided in Belle, and their reported anxieties, their worries, their tips, their understandings can give us crucial insight into how disability was indexed to family functioning. Some women, for instance, carriers of Fragile X syndrome, were concerned about their ability to care for more disabled children. And so they asked and received sterilizations, demonstrating that sterilizations, in fact, did happen in the UK in a way that has been somewhat glossed in the historiography, and also showing both reproductive agency and a more complex relationship between disabled people and eugenicists than has been hitherto suggested. Belle worked with families to try to give them more, not less, control over their lives and their futures. So for instance, she worked with the biochemist and later Medical Research Council Secretary Edward Mellanby to establish the supremacy of hereditary factors over nutrition in the case of certain disabling diseases. Belle wrote to Mellanby in 1934, explaining, "I have lately been seeing members of a family in Somerset, 23 of whom have perineal atrophy. They're very, very intelligent and plucky, get good jobs and do well in spite of their severe handicap. The young folk dread the onset of the disease and their parents are terribly anxious for their children." And after meeting with Belle, Mellanby, who was really working a great deal during the interwar years to advocate the use of milk for mothers and children, as Fran was, I'm in the archives right now, and I found a fantastic quote from him the other day where he says, in relation to a debate about the use of milk and how they can get it out to the public, "I am not interested in feeding people with statistics." So becoming increasingly infatuated with Mellanby. But anyway, in this case, he said to Belle that he gave her some suggestions as to the kind of diet that might be advised in the case of a number of younger members of the last generation, where it appeared probable that the malady would develop. I told her that I did not have very much hope of its affecting any prevention, but that it might be worth trying. So this is a kind of example of a collaboration between eugenicists and families that demonstrates both the complexity of eugenics and the importance of clearly defining eugenics across both times and disciplinary perspectives. For many disability historians, eugenics remains alive and well in the social pressures surrounding current reproductive technology, while for most historians of science, eugenics is a historically bounded and discrete project linked to Galtonian geneticists. And this is a division that has been described by Jacine Wegner as emblematic of both discussions about eugenics that reify crude analogies and ahistorical comparisons, and that highlights differences between the embodied epistemologies of disability studies on the one hand, and the seemingly disembodied epistemologies of traditional studies in history on the other hand. And what I'm trying to do is try and combine these two approaches. And I think, Belle's work is something that really exemplifies the contradictions and the continuities of interwar eugenics. And as I said, Belle was at Cambridge. She originally started work on biometrics in 1908 under the supervision of Carl Pearson after taking a degree in mathematics. She was at Girton College. And she became an integral statistician in the Treasury project from 1909 onwards. Her work was especially important to establishing the existence of sex-linked conditions like haemophilia and colour blindness, which she worked on with JBS Haldane in 1936. This meant that her work tended to focus particularly on recessive conditions, things like Fragile X syndrome, a developmental disability linked to the X chromosome that was actually originally known as Martin-Bell syndrome. So it was originally named after Belle and her colleague Martin. Despite her integral role in the Treasury project, she was paid substantively less than the other researchers on the team. And interestingly enough, Carl Pearson was the person who intervened and who fought to increase her salary after she was refused a fellowship on account of her age. It took me a while to work this out, but I think it was because she was too old. She was like 30, so it's a bit unclear. But her lower salary was justified by the medical statistician, Dr. Major Greenwood, who was then the head of the Medical Research Council's Statistical Committee, with the explanation that, of course, £300 a year is a very small income, but I think it may be said to represent a pre-war income for a single woman without, so far as we know, dependents of almost £200, and is therefore not below what used to be regarded as a fair scale. Yet by 1932, she had a very reasonable personal grant of £450 per annum following Pearson's vociferous campaigning on her behalf. And this is an anecdote that I think fits really nicely into a satisfying kind of victimhood narrative suitable for the kinds of promotional narratives that are often emphasised when we write about women in science. However, a disability history perspective ensures that we don't fall into the trap of replacing the great man of science myth with the equally pernicious great woman of science myth. It allows us to question, for instance, whether the women that were fighting to break into professional science at this time did so by creating more restrictive criteria over what counted as an able body and an able mind, almost paralleling the ways in which working class men professionalized science earlier in the previous century by excluding women in the first place. But when the First World War broke out and work on the Treasury ceased, Bell went to the Royal Free Hospital to obtain her medical degree, and she only actually returned to the Galton Laboratory in 1920. She then worked under the supervision of first Ronald Fisher, then Lionel Penrose, and was responsible for writing approximately 13 volumes of the Treasury. And verifying the correlations between potentially social factors and establishing the relationship to inherited factors was really the crucial part of Bell's work. It was what she was trying to do. And so she investigated things like parentage, obviously, but she also looked at things like diet, smoking, alcoholism, drug use, breastfeeding. She considered things like how gender affected caregiving norms, how it affected the tendency and the ability to conceal disability, how it worked in relation to becoming a barrier to marriage, as well as thinking about things like class and education and institutionalization. And this was critical to her work, demarcating genetic influences from environmental conditions. So for example, here you can see when working on nervous diseases, Bell noted that it is difficult to say how much of the mental backwardness can be attributed to the lack of independence and lack of stimulus to activity of any sort, resulting from the conditions under which the patient must live. So she explained the pressing need to understand how disability and disease were reacted upon, quote, by economic and social conditions varying from one period to another or from one country to another. And this was linked to the related need to sort the relative importance of different individuals' genetic susceptibility, as she saw it, due to their categorization as part of a group, separately from ways of living as members of that group. So Bell's work necessarily involved establishing the apparent impacts of sex-linked conditions from the effects of gendered norms. Although it was clear to her that certain conditions were linked to women, it wasn't clear to her why. And this is something that comes up in particular in her 1932 annual report to the Medical Research Council, when she's talking about dislocation of hips and ribs occurring more in the case of women and children. Similarly, she was concerned that sex differences in glaucoma were not due to, quote, vasomotor instability in women at certain periods of life, as had been supposed, but rather she thought they were the result of gender differences, like, quote, the tendency amongst women to neglect minor symptoms. But Bell reverses this causation when she considers racial differences in the same case in glaucoma, in response to the point made to her that greater propensity among, quote, Jewish people to glaucoma was due to greater diligence in seeking care. She argued that, in fact, this demonstrated proof of a, quote, Jewish genetic disposition to nervousness, which then precipitated the disease. And she also explained the pressing need to clarify why there was, quote, a very marked difference between the values of the sex incidence for the Eastern and Western races. So I think this is just a nice example that reveals how power can influence categorization decisions and how the categories used in genetic research, including race, gender, and class, were constructed in order to establish disability. These categories weren't fixed, but shifted and fluctuated in relation to the different contexts of eugenics, genetics, and compensation cultures that sought to explain the causes of disability and allocate responsibility for it. As Ted Porter has succinctly put it, human genetics could never be confined to the laboratory. And I think these kind of sources can also reveal a surprising potential for recovering lived experience, even though it might not seem like the most obvious source to look at for that. But for example, if you look at the 1928 volume of the Treasury on blue sclerotics and fragility of bone, you can see that Bell attempts to identify the onset of several clinical symptoms related to the genetic condition in question. And reading along the grain, sure, these are examples of medical case studies, but reading against the grain, they do provide fascinating little glimpses of the diversity of disablement and its management within families, including indications that some affected individuals considered their condition to be a good thing for them. So, for example, Bell described how one man with hyperextensibility of ligaments, common in association with blue sclerotics, used this extensibility to make a living as an acrobat on stage, who stated that he could do looping in the air. And his framing here suggests that he considered this condition to be a positive asset. Similarly, Bell tells us about one woman who, quote, volunteered the statement that her 3 children were all born with eyes just like hers, but the eldest lost the blue in the first year of life. The unsolicited description of her children's eyes as just like hers suggested that what Bell regarded as the normalization of a defect or a cure was regarded by the mother as a loss. Other women, such as the 29-year-old who acerbically commented that she was, quote, aware that my eyes are of great interest to nearly every doctor I meet, articulated a kind of ambiguity around desirability and normative appearance rather, to reveal this tension between the clinical gaze and lived experience. And this tension could actually become active resistance, such as the case of a man who argued with Bell that he did not have bone fragility and that all of his injuries were the result of his love of wrestling. So in these kind of examples, we see the clinical gaze reflected back onto the viewer, and this pushback against the non-disabled, white, heterosexual context of this source enables us to reframe, recontextualize, and rewrite these stories from a disability history perspective. And these sources also provide some examples of how disability could be managed quite outside of medical spheres and medical settings, encouraging us to consider just the perspective from what Mick Warboys has recently termed the non-patient's view. The 1928 volume alone lists numerous examples of disabled innovations, ranging from use of a vegetarian diet to particular prostheses such as crutches and splints, ear trumpets, and carefully deployed spinal jackets. Reframing patients as users, then, can add to historians' efforts to recover patient voices by considering experiences far outside the clinical encounter, offering access to the experiences of the disabled who didn't consider themselves as such, and certainly did not consider themselves patients. And this links to some wider points about method, because disability historians have tended to argue that administrative and institutional data cannot tell the stories that disability scholars seek most to retrieve. This argument rests on the idea that such data sets cannot tell us anything about lived experience of disability and will in fact work to reinforce ableist assumptions. This is really linked to the force of the medical social model binary, which has further influenced the tendency of disability historians to work away from sites of medicine or sites of science. And while it might be true that lived experience is less accessible in such historical sources, I contend that these kinds of sources can be extremely valuable for revealing the scientific and statistical construction of disability. Combining disability history and the history of science, it can thus advance our thinking about how both disability and eugenics relates to a broader history of categorizing inequality. which has blurred the relationships between the environment and the individual. And Mariette Schmidt's recent work on genetic deafness is a brilliant example of the effectiveness of a history of science approach to disability history. And I think Andrew Hogan as well, some of his work is doing this really nicely in the US context, both of these. But essentially what I'm trying to say is that working out how and when disability has been established as an objective departure from normalcy or normal functioning can widen the lens of the disability historian. The scientific categorization of disability as natural, as inevitable, can only be uncovered by critically questioning the legitimacy of the paradigms that supports this kind of framing. So by questioning the basis of exclusion or the acceptance of socioeconomic factors, we can push at this normative scientific scaffolding that supported the understanding of inheritance that really emerged against a particular background of widespread First World War disablement and the proto-welfare state. And this is a really significant context, as historians like Alex Mould have emphasized. She writes that emphasizing personal responsibility for health shifted liability. The importance of socioeconomic inequalities diminished in the 20th century as classifications of standardized types linked to race and age and sex were elevated. By critically engaging with the scientific processes of categorization, we can complicate the biological versus social binary by illuminating the cases, the people, and experiences that blurred this borderline's limits. And framing the moves made to try and classify disability as either genetic or acquired reveals the epistemic work that classification systems, whether statistical, as we've discussed today, or compensatory, did to codify interactions between the biological and the social. And historicizing the creation of this binary, firstly, reveals how data has been used to obscure health inequalities by obscuring this relationship. And secondly, reveals how disability acts as a meta-analytic category that gives credence to these other salient categories. This reveals the epistemological power of categorization in its creation of disability as a difference that mattered and that could be counted, classified, and controlled. Ruha Benjamin has shown how this kind of process entrenches race categories in technoscience by asking, quote, what social groups are classified, corralled, coerced, and capitalized upon so that others are free to tinker, experiment, design, and engineer the future. Problematizing these categories themselves emphasizes their epistemic authority, their imaginative power, and most importantly, highlights disabled resistance to them. Thank you.